Everyone, to today's webinar, Behavioral Health at Scale, How Top Health Systems Are Optimizing Service Lines to Deliver Care Across the Continuum. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. With that, I'm pleased to turn the floor over to Andy Flanagan, Chief Executive Officer at Iris Telehealth, to begin today's session.
Thank you and welcome everybody. We have an outstanding panel on a critical topic. Everyone on this meeting is trying to figure out how we improve access and outcomes in behavioral health at scale. And we have two experts from health systems that are really leading the pack. And so we have the opportunity to hear them. They're going to speak for a few minutes and present some slides about their approach and their system. And then, as the moderator mentioned, we encourage you to submit questions, and we'll spend about 20 or 30 minutes just discussing topics at large. So I'm going to briefly introduce our panel, and then we'll get started. My name is Andy Flanagan, CEO of Iris Telehealth. We're joined by Dawn Zeiger, who is the Vice President of Behavioral Health and Psychiatry at Geisinger Health System. And we're joined by Joe Clubb, who's Vice President of Operations, Mental Health and Addiction at Allina Health System. So welcome everybody, and thank you Alice for attending and us through the conversation. Dawn, I'm going to ask you to take us away.
All right. Thank you so much, Andy, and thank you all for the opportunity to talk about such an important topic. I'm really proud to be in a health system that's making big investments in behavioral health at a time we know the economics of healthcare are very tough. So I'm going to share a little bit about Geisinger as a whole, and then a couple of partnerships that we're doing to strengthen the continuum of care. So we are a large integrated healthcare system with $8 billion in combined revenues. We have 10 hospital campuses, 130 clinic sites. We see nearly 1 million patients. If you were to look at our footprint, this is where we have services throughout central Pennsylvania. If you were to overlay this with the HRSA mental health provider shortage area, you would see all but 2 of our counties are in mental health provider shortage areas. So we really have a challenge recruiting the workforce to meet the needs of rural Pennsylvania. So as we talk about building out behavioral health services, we really want to think about the full continuum. Sometimes people conceptualize behavioral health as their outpatient therapist. Sometimes it's what happens in an inpatient psych unit. But just like medical treatment, there's a full continuum of resources that are needed to meet the various needs of our community. So we're going to focus on a couple areas today. I'm going to talk a little bit about a joint venture partnership that we have for the inpatient side that also serves partial hospitalization, intensive outpatient. And then I'm going to talk about expansion that we did with Iris and with our internal Geisinger resources to really scale outpatient services in a very rapid manner. So we'll start with inpatient facility. We are in one of our markets about 300 beds short. In the other market, we literally have no inpatient psychiatry for child and adolescent patients. So I'm a mom of a teenager. I can imagine her being in crisis and having to send her 3 hours away for care. That's not where the situation we want to be in. So we have partnered with an expert in inpatient psychiatry care, Acadia, to build 2 96-bed hospitals. Very excited. The first one's going to open actually in 6 weeks. We'll be opening one in the Scranton area, and then to follow one in our more rural market in central Pennsylvania. So on the outpatient side, this has been just the story I think a lot of us have been feeling. We had a waiting list of 18,000 referrals of people requesting mental health care in the middle of the pandemic. Through rapid expansion, we got that down to 3,000, but you see the bouncy ball, we're back up to 9,000. So this is one of those situations where there isn't enough workforce in the country to meet the incoming needs. So we've got to think about this differently. When we look at our daily referral volumes, we get about 180 referrals a day. So that's about a half of a psychiatrist. So if you think about that, I'd have to be hiring a psychiatrist every other day to keep up with the demand if we don't change the way we do business here and serve the masses. So one of the strategies we took, you think about COVID, we surged to the hospitals, right? We put all the resources to the hospital to care for the patients that were in our ED. At Geisinger, we treated the mental health situation just like a surge of COVID, and we surged resources into our communities. And one way we did that was to take providers from all over the country and bring them to serve rural Pennsylvania. One of my favorite stories was there's a guy I sat next to playing trivia for 2 years. And he asked me what I did. And I said, oh, I work in psychiatry. And he said, one of the people in your team has saved my life. And this is a doctor that's in Atlanta, Georgia, serving somebody in rural Pennsylvania where there are no psychiatrists here locally. And so virtual care has really helped democratize access to care in our communities, and has helped us to serve in a way we never could. In the pediatric space, we had one pediatric psychiatrist. We now have 13 throughout the country. And those are employed by Geisinger in addition to the resources that we have through IRIS. So the other thing, we mentioned 180 referrals a day. There's no way that we can keep up with that. So one of the things we're really thinking about is how do we scale groups in a new way so that we can see more patients with limited resources. So we, at the time, had about 4,000 outstanding adult therapy referrals. That number is more like 6,000 now. And we're trying to rapidly roll out groups for anxiety and depression to scale even further those virtual care providers and meet people where they are. Longer term, we want to make a paradigm shift from individualized care, building upon that and looking at panels of care. So how is a particular provider managing their patients, not only their behavioral health outcomes, but their medical outcomes? And then we want to start thinking about things like population-based care. How do we detect that patient that maybe is only seen in primary care and has an exacerbation of depression and shows up in our emergency department a few times? How do we start to monitor our populations to identify those patients so we can proactively outreach to them? And so we're on a very small step in a very long journey to help close this gap with behavioral health care. Really welcome the thoughts of the folks attending on how they're tackling this issue, because it's going to take really rethinking the way we do things to meet these urgent needs of our community.
Thank you. Thank you, Dawn. Joe?
Yep, thank you. I appreciate, Dawn, your presentation. I also welcome the dialogue after the presentation, sharing a perspective from a line of health, but know that there are other experts out there in the audience that I'd love to learn from. If we could advance, yep, thank you. So I start with this slide. We have an overarching philosophy at a line of health to address whole person care. And so our approach within a line of health is to really think about mental health and addiction care as part of healthcare. So we really look at addressing the whole person. We've intentionally integrated mental health and addiction services into our healthcare system. I know that there are different approaches to do that. And as mentioned in the previous presentation, looking at partnerships with Acadia, and that certainly is a approach that some of our sister healthcare systems are looking at within the Minneapolis and St. Paul area, as well as the state of Minnesota. So if we could go to the next slide, I would appreciate it. So just to give you a little perspective on a line of health, I'll talk about a line of health and then talk a little bit more specifically about mental health and addiction. So we are comprised of 11 hospitals, and we have 90 clinics. And that's a combination of clinic, urgent care, and hospital-based clinics. For us, our hospital-based clinics, we use that term here. They are integrated onto hospital campuses. Those are our specialty clinics, as well as looking at our rehab services in Minnesota. The former Sister Kenny and Courage Kenny, now Courage Center, have merged together to strengthen and rehab services. We also have a our retail pharmacies as well, and then mentioning some of our medical services, our specialty services, home services, and hospice. And we do span the state as it relates to EMS services. We span from north central Minnesota down to southern Minnesota in our service area. We can go to the next slide. I want to focus more into mental health and addiction. So we are comprised of 250 inpatient beds across our state in 7 sites. What we're very proud of at Allina Health is we do serve the lifespan. So for us, that means children, adolescents, adults, and our seniors. In addition, we have been integrating psychology services into our inpatient mental health and addiction units, along with other adjunctive therapies. Within those 250 beds, we have a unique 10-bed residential addiction treatment program in southern Minnesota, and we have a 24-bed 3.7 level or ASAM level of addiction care up in the metro area. We've gone through a transformation within our emergency services, and so we do provide brief treatment and intervention within 12 emergency rooms across Allina, along with 4 affiliate hospitals. We have added psychiatry services within the emergency department, and that includes our partners in IRIS, along with those staff that we have employed mostly in our metro sites, and then really working with IRIS to support those metro sites and expand into our regional locations in greater Minnesota. At the time that we have a philosophy, we're going to maintain the 250 inpatient beds, and that's a conscious decision, no less, no more. But we have been very focused on building out our outpatient or intermediate levels of care. So that's broken out into partial hospital, day treatment, and outpatient addiction. We started out with about, just to give you a sense of growth, we started out with about 250 chairs, and we've now expanded, and it continues to change. And I will have to update this slide because we are now over 725 chairs for partial and day treatment, and then have maintained the 144. I emphasize this for a reason, and that is that we built out our outpatient services in a very robust way, 1 year by 30%, the subsequent year by 25%, and then we'll finish this year with another 15% growth. We did that so that we would have alternatives available to inpatient admissions. So in the emergency department, where there's brief treatment and intervention, there are psychiatrists along with the clinicians, both IRIS and our staff psychiatrists. They have options to take the pressure off the patients that are in the ED and giving them an alternative to an inpatient admission. In 2019, we were discharging about 55% of our patients out of our 12 emergency departments to an outpatient program. We just finished 2022 at 63%. And it's really made a difference having psychiatry available 24/7, again, with IRIS and our staff, to be able to drive that. In the outpatient areas, because of the rapid growth, as had been previously mentioned, we can't hire our way out of this shortage. We continue to do a great job with recruitment, but we rely heavily on IRIS partnership to staff that growth in our partial and day treatment programs. So we've actually used it to keep those partial chairs open and have access so that our inpatient discharges and our ED patients can have access. Now, I do want to speak to our hospital-based clinics and then our integrated primary care model. It is our belief that if we can really proactively address the needs of individuals through our primary care clinics, we can actually avoid those crises and the need to go to the ED. So we have about 25 psychiatrists, nurse practitioners embedded in primary care. We have about 80 psychologists that are embedded within primary care, and we just introduced a new role called a mental health consultant. And that mental health consultant is a clinical social worker that is embedded in primary care, and we create open access and take all of our initial appointments through them, and we actually address their needs, whether it's social determinant needs or psychiatry needs, and we do bridging appointments to different levels of care. What I want to go back up to is I joined Allina 8 years ago, and one of the first things that hospital presidents said to me, and it was mostly our greater Minnesota sites, is that they had no psychiatry coverage in our regional EDs, and they have patients on med-surg units who had medical and comorbid mental health needs, but they were stalled and unable to progress patients on to discharge. So that's where the partnership with IRIS really started 8 years ago with us. It was long before the pandemic when everybody was into virtual care. We were really leading in this partnership through telehealth. So we hired IRIS psychiatrists to do consult liaison work on med-surg ICU, and then to staff our EDs 24/7. I have to tell you, that has had some of the most, the greatest outcomes. It has actually, I never hear from hospital presidents about lacking as it relates to that service for our teams. And so we also built up a consult liaison service on our med-surg units within our hospitals in the metro. And we partner with IRIS in that. Again, don't have the bandwidth to cover all of our consult liaison services, but have been able to do that through this partnership. And so I'm gonna, I think I'm at the end of my slides, and I think that's what I wanted to speak to as it related to our continuum of care.
That's great. Thank you, Joe. Thank you, Dawn. So we're going to dive into some of the Q&A. You can see some of it. We also have another thread over here going. I'm going to lead us through these, and we'll just go round robin if that's okay with the two of you. So I'll read the first question, and maybe Dawn, you can start, and then Joe, you can add your perspective.
Sounds good.
The group wants to know how you prioritize your biggest challenges, specifically around access to quality care across the entire continuum. So, what are your biggest challenges, and how do you prioritize which one to work on first?
Yeah, Andy, that's a great question. I don't know that we fully cracked the nut on where to start, but I can tell you what we're thinking. Everybody wants a therapist. Everybody needs a therapist, frankly. But all of our services, our medical services, pediatrics, everybody's coming to us really wanting us to develop out the mental health continuum of care. How we're conceptualizing it is we're going to be doing a care model evolution exercise where we're going to go community by community. We're going to look at how many people are in that community, how many people based on prevalence do we expect to have a mental health condition, what resources do we currently have, what don't we have, and we're going to really try to throw that all out to understand where we really need to be focusing, because truly, you get a community health needs assessment, every county says needs behavioral health. So the question is, where do you start? So that's one approach that we're taking. Another is looking at the known demand. So when we looked at the 18,000 referral work queue, we start to say, gosh, is this therapy needs, is this psychiatry needs? That's how we came up with the group strategy of really focusing on those 70% of referrals that are anxiety and depression. How can we really focus a limited resource to meet a broader scale? So I think it's going to be multiple iterations of kind of working community by community, finding what's financially sustainable, where we can get grant support, and then kind of tackling it a step at a time.
I would offer to that. We have many of the same challenges, and so it really is a multi-pronged approach. So while we were embedding psychiatry into EDs and clinicians, we changed our model to be not just are you in or you out, but really starting care in the emergency department. And so we call it brief treatment and intervention. So it's medications and brief therapy, which is driving that discharge away from an inpatient admission. We, as I mentioned, the mental health consultant who is a clinical social worker, we started that program as a pilot. We started it with 2 clinical social workers, and it's now grown to 40, and we're still hiring into that. And we found that to be one of our greatest tools of triage. So everybody needs a psychiatrist, so you think, and that's what people think they need when they ask for that. And so it is our mental health consultants who take appointments every day just to triage, and they get people to the right level of care. And then what they do is they bridge appointments. Our goal is to bridge within 6 to 8 appointments to a therapist, a psychiatrist. We also use electronic approaches or digital approaches. So when we screen individuals in primary care through our PHQ-9 screening, which I know all of us do, we actually refer low-level depression to a digital solution that is coached. It's a coached intervention. And so in this last year, we actually took and offered this to just over 500 patients. And these would have been 500 patients that we would have probably referred into face-to-face therapy. And so it has helped us to solve that. The other is we have a digital solution or option for addiction, and it's an adjunct to addiction care. And then we use a suicide intervention tool to standardize our interventions for those patients in our emergency department who are feeling suicidal, and starting that treatment and intervention, which culminates in a safety plan that used to go out with into a patient as a piece of paper and become obsolete the minute they left the building. And now it is a digital option that is uploaded to our electronic record, that when they go see their therapist or their psychiatrist, you can update that safety plan, and it's a live document. So I would say Iris was our first telehealth option, and then really looking at these. I will say that with all of us through the pandemic, we all stood up virtual therapy, virtual partial, virtual day treatment, virtual psychiatry. That has served our patients in our community extremely well. Mm-hmm. They don't have to navigate parking in a ramp, navigate a building. Our attendance to appointments increased by 10%. Our patient satisfaction scores went up by 5%, just a huge satisfier. And I would say that virtual care is here to stay as long as we can get our government payment and our health plans to join us in that and continue reimbursement. So I'll pause and we can get to the next question.
Can I add, Joe? I completely agree with you. Virtual care has been transformational for us. I mean, you can see things when somebody's in their home environment that you're not going to get that same experience or perspective when somebody's coming into the office. And so, we really think it's here to stay as well, and are advocating strongly for policy to support that and payment to support that.
And I think there are two things there just to build on. Let's tackle the reimbursement first. Obviously, no money, no mission, and behavioral health has historically been a challenge from a reimbursement perspective. How are you thinking about making sure your programs are sustainable, and how are you thinking about the long-term longitudinal benefits of integration of behavioral health as the total cost of care in either one of you? Joe, you want to go?
Go ahead.
Yeah, so what I would offer to you is that certainly through the public health emergency, there was a lot of latitude to be able to serve individuals virtually. We're starting to see the policies change with the ending of the PHE, and so we're worried about that, to be quite honest. And we have been working very closely with our Allina Health Public Policy Division to be able to comment during opening statements when there are rule changes in that. Some of the changes we agree with. So we do understand and recognize that a partial hospital program is the highest level of care in our outpatient settings. And we recognize and appreciate that those should be in-person services. But there's a hard reality, and that is that we have greater Minnesota that we have been able to serve individuals through a virtual partial program because there has not been a partial program available in their community. So our argument is, wouldn't virtual partial be better than no partial for somebody who's in greater Minnesota. And we have brought back in person our partial day treatment programs, but we still are maintaining a virtual track. We've organized it so that it's not every site is offering virtual care, but we have a virtual program that we've organized to meet that need. The same is true for our highest level of clinic care, which is our hospital-based clinic care. And so that is one that we're getting pushback that if we offer it as a virtual option, that the facility fee reimbursement will go away. Our argument is we still need to pay for those disciplines that make up that team-based approach in a hospital-based clinic. So the registered nurse that does nurse clinic. We also need the clinical social worker that does the case management. You know, there are components that we're asking for consideration. We agree we'll get people in when they are able, but we want to have some latitude for those that's an absolute barrier for them.
Great. Don?
Yeah, I would say from the financial standpoint, you know, we're in a process of taking the whole revenue cycle apart bit by bit and asking a question about every code, every discipline, every contract, and to really set the stage for being more assertive and setting rates. We know that somebody with a behavioral health condition has medical expenses that are 2 to 3 times higher than somebody without a behavioral health condition. So we're also looking at what's the per member per month impact of providing behavioral health services to folks. You know, we want to have the value conversation, and the reality is we all live in a fee-for-service world. So I think we have to do both and really advocate for the rates that are needed to cover the costs. We are really setting the stage with our contracting team and strategy, whereas before we would just take whatever was offered to us. We're going to put an offer out there first, and we're going to see if we can really get the reimbursement we feel like we deserve for this large investment that we've made.
Mm-hmm. That's great. You know, a big part of having that conversation about reimbursement or any rule change is quality and outcomes. Can you talk just a little bit about how you're managing quality? You have both on-premise and virtual providers kind of operating together, intermeshed, if you will.
Yeah, I'll be glad to take a swing at that. And then Joe, I'll pass to you. We really, when we partnered with Iris, we were looking for somebody that it would feel the same to the patient, whether it was an Iris hired provider or a provider we hired that was in Texas. And so we have the same quality reviews, FPPE, OPPE expectations for our contracted services as we do our employees. Now, that being said, I think we have a lot of opportunity, not only at Geisinger, but industry-wide, to improve and bring black and white quality to things that can kind of be gray in the behavioral health space. We're starting to really look at readmissions and some of the tangible access type metrics. We've got those down. It's, are we improving quality of life? Are people healthier? Our diabetics that see a psychologist decreasing their A1Cs. And so we're really building that foundation of quality, but not only from the behavioral health aspect, we want to look at it from the whole person care perspective. And again, we're taking a step along this journey that's going to be a multi-year or career journey for us to really wrap behavioral health quality into the overall whole person care.
Yeah, I would offer that when we started out with our partnership with Iris, I have to tell you, we learned together. We learned together, and all of the Iris providers are credentialed Alina providers licensed within the state of Minnesota. Sorry, I've got a paging going on behind me. Okay, and so what I will tell you, we have one medical director. We started with one medical director who was the point person with Iris and would offer feedback if there was any concern. So then there was the appropriate review process and that. And I have to tell you that the response from Iris was incredible and working to address any concerns that might be raised. Now, as we've grown, we have medical directors for ED services and our CL service. So they have become primarily the point people. I'll give you a very good example. We had a period of time where I was providing CL doctors a different doc every day for our med-surg ICU consult services. gave them feedback that that wasn't working for us, that we needed more continuity. And so started with one site and started with the same Monday through Friday CL doc to cover that location. Really great feedback from that, and that continuity made a difference. The other piece or infrastructure we put together is we meet both virtually and in person with Iris on a quarterly basis, and we meet together to discuss and review, kind of do a retrospective review, but then we think about the future together. And the last comment I will make is we are held to outcome measures and quality measures within a line of health. And so we met with Iris, and we're very transparent in sharing with them. These are the outcome measures that we have put out there as safety, quality, financial, and we want to share those with you. And so we actually aligned those, everything from length of stay to looking at the PHQ-9, so looking at all the different outcome measures. And so we look at the data together, and we look at it as outcome measures related to a line of providers and outcome measures related to Iris. And I will tell you that there are times where we look at the data and Iris, though virtual, is hitting the mark, or sometimes we'll see them at a higher rate of performance. The last thing I will say, when I knew that this really made a difference for anybody who was a naysayer to virtual care, we actually use Iris to provide vacation coverage to our inpatient units. It's tough to staff 250 beds, and providers need to go on vacation. And so we have 2 full-time Iris providers that cover our inpatient units. And the feedback I got from a family conference from the leader on one of our geriatric units is how impressed everybody was as to how well that Iris provider, that psychiatrist, knew the patient and their family. And that Iris provider joined that conference. Everybody else was in person, and they were there virtually. And so just their stories and their data that we look at to assure quality.
Joe, I'm glad you mentioned the inpatient side of things, because we also are doing tele through employed providers. And, you know, we've been able to recruit some amazing docs that we wouldn't be able to draw to this rural community. And so we've integrated inpatient telepsychiatry with in-person APPs so that we've kind of got the best of both worlds. We're not sure if the regulations are going to hold, you know, so right now we're kind of holding on and seeing what's going to happen. But we feel like we have to be realistic that, gosh, the recruiting, the market's changed. Psychiatrists can work wherever they want from home. And so, you know, I think we have to continue to beat that drum. Another point along the lines of what you shared is I just spoke with a payer yesterday, and I said, gosh, if you're looking at quality, what's coming through your door, knowing that the far majority, 90% of my outpatient services is virtual, I said, what are you seeing? They said, your notes are more robust. The way that you're approaching things are much stronger. And so from an outside kind of perspective, they're seeing no inequity between in-person or virtual, and in fact are seeing a higher quality output from our virtual care across the board.
It's great. Great insights. I want to kind of roll the tape forward a little bit. And, you know, if you think about the integration work that you each have done of virtual and on-premise, there are probably still some pockets of resistance or adoption, areas that you'd like to integrate into more deeply. So maybe you could talk a little bit about some of the challenges, you know, in your next leg, if you will, if you were to look forward over the next 18 months, maybe something like that.
You know, I would offer to you that we have really had great adoption of virtual care. Where we're getting the struggle is we're having struggles getting people to accept returning to a clinic to actually see they got very comfortable working from their home. And even though some of them started out doing care in bathrooms until they could get their home office set up and those kinds of things, because that was the only private room in their house. But now we're still sitting at about 65% of our providers are still providing virtual care. especially within our clinic settings. It's those higher level that we have asked that they come back, the partial programs, the day treatment, and some of those programs and that. And I will say that here's what I imagine the future will be. I imagine the future will be a third, and a third. I believe there will be a third of our providers that will be 100% virtual offsite. There will be a third that will be in a clinic setting, seeing both in-person visits from their clinic and then virtual from their clinic. And then there will be a third, and we do have some that absolutely prefer in-person over virtual. So I see that as our future. Now, where it has helped us is we're building out a mental health and addiction specialty center that's an integrated center in one of our northern suburbs with community partners. We were able to reduce capital costs because we didn't need as much bricks and mortar as we originally had thought because of the ability to have the virtual care option. And so we'll be able to meet our volume projections between the on-site services and virtual care. So that's what I would offer.
Yeah, I think our perspectives is probably a little bit more skewed towards virtual just based on the majority of our service area being a mental health provider shortage area. You know, I was reviewing patient experience comments a couple hours ago, and there's still people that really want to see the in-person. And so we've got to figure out how to develop that workforce locally. What I keep thinking about is we've got the scalable virtual chassis of being able to recruit nationwide as long as everything still holds. How do we take maybe a different resource that's more locally available and have that be the front door? Whether that's an LCSW, whether that's a peer, a certified recovery specialist, that's a workforce I know I can draw, APPs I know I can draw in this community. So how do we marry the two so that it feels like the same care team? The other concept that we will be implementing in the next 12 months is localization of virtual care. So when we scaled rapidly, you know, anytime you scale rapidly, it can be a little messy. We added 53 providers in the course of 12 months, which was significant. We did not, it's all kind of run through the same funnel. What we want to do now is take those virtual providers and embed them in communities. So if you're in Texas, you might be serving the coal region of Pennsylvania, and you get to know the local primary care providers, you get to know where there's a PHP, you start to understand the community resources. And so we're actually going to localize our virtual care so that that becomes more a part of that local ecosystem. And so I'm very excited to see how that outcome, how that impacts our primary care adoption, how that helps us to transition patients back, because we should be able to build more trust as we have more of those localized relationships.
That's great. So one question, the two of you have strong established programs, and many of the people listening are at the beginning part of the journey. So can you offer your suggestions or how you successfully garnered executive support, and how do you maintain that for, say, outpatient specifically? But any aspect of your program, what advice would you offer about either gaining or maintaining executive sponsorship for your programs?
I'm still learning. Don't assume everybody knows what you know. Like, don't assume people know that the medical costs are 2 to 3 times higher for a person with a behavioral health condition. Don't assume people know how much unmet demand there is in the market. You got to tell the full story. You will feel the tension of all of these folks coming to you wanting services, but the executive leadership may not fully know that. They may not know how it's affecting their ED throughput. They may not know how many patients need addiction treatment that are being detoxed and discharged because we're not integrated as much. So I would say don't assume knowledge of what you know. Secondly is, you know, we're in a financial environment that we've got to be financially sustainable. Services like primary care in the past have been loss leaders to get people into specialty care. But you know what? I don't think we're in that era right now. So we got to make sure our fee-for-service game is tight as it can be, and that then we can speak to value on top of that. Because I know in my environment, you got to have the value, you got to have the fee-for-service, and you got to have the compelling story about how to serve the community.
Yeah, I would offer that we are in a really, really tough financial environment like everybody. And we started out our journey, about 6 years ago, like everyone, we had such a crisis with patients staying such long periods of time within our emergency departments. And we just really needed to not just address that alone. And I would say it's been the value of our primary care integration that has really had a significant impact. So while we were changing the clinical model within the emergency department, we really continued to build on that integration and be proactive in that area. And so I think that, one of the things that if you could start with creating those relief valves for your high demand in your emergency departments, that would be a great first place to start. So it was really that building out that outpatient continuum, because you have to have options. The other thing I will say is that at Allina Health, we were really comfortable recognizing our expertise within mental health and addiction, and realizing and identifying in the community those expertise that actually we would not replicate or duplicate, and knowing that these community-based agencies have an expertise and, quite frankly, could provide the care cheaper than we could. And so we have 17 different partners across the state. And I'll give you one example, and that is we have a nonprofit children's agency that provides in-home crisis intervention for kids. And they do this through clinical social workers. And so we've been paying upfront for 3 full-time clinical social workers to actually take handoffs from our inpatient child adolescent unit and from our ED to take kids and their families home to take care of them. And so we average about 300 children a year that we're able to serve. And I will tell you that in looking at the outcomes, looking at the readmission rates going down, looking at a shorter length of stay, and decreasing volume within our emergency departments, that investment has actually paid off. And we actually do a true-up with this organization where they reimburse us for the billable services that they can provide. So it's been a win-win. And so, I would say that we started with Iris, but we've really expanded now to 17 different partnerships with our agencies, because we can't do it alone, and we need to recognize experts.
Yeah, we've been talking a lot about how mental health care is a team sport, right? And it's not, all of us have different expertise. And so I really appreciate you bringing that part of the conversation forward.
Yeah, that's an impressive outcome, Joe. We all have a responsibility to advocate for the policy changes that will make a difference in the future, or we need to retain. What would you suggest to the listeners would be the top 1 or 2 areas or policies that we collectively should be focused on in our advocacy efforts? Any thoughts?
I think we talked about this a little bit before, is really recognition for virtual care as a modality, and for compensation for it. So like Joe mentioned, we may not have that person in a clinic, but we still have to provision them with a computer. They still need support staff. We still need somebody to pick up the phone when they call. And so I think there's a perception that we should be paid less for virtual care. And, I think that's an area we need to advocate for strongly. And then, I don't know how close everybody is to this, but with changes at the DEA and reinstatement of the Ryan-Hyde Act, and looking at prescription of controlled substances, it literally, if they reinstate that, will remove care from communities that don't have other options. And so I think we should be advocating that this is a safe approach for care, as long as appropriate controls are in place. And then it's on us to make sure that we maintain the quality oversight and the things that we will do to make sure this is a mature model of care.
I want to piggyback on the DEA issue, because we have a virtual addiction service where we have providers. So we have those that can prescribe Suboxone. We also have virtual therapists that do group and individual therapy. We started this before the pandemic in a very small pilot way, and it's really grown and expanded. We primarily take referrals out of our emergency department. We do take referrals out of primary care as well to provide this, but we have people that we serve in northern regions and southern regions of Minnesota that if we can't get them in for an in-person evaluation and we take them off their Suboxone, it just is counter to how we want to address the opioid crisis within Minnesota and across the state. And it just makes no sense to me. It's a really poor decision. And we, again, where there's the opportunity to have that face-to-face, we fully support it. We just want the latitude to be able to support those that's impossible.
That's great. I'm going to take us in a slightly different direction. You know, as you both know, at Iris, we're technology agnostic, yet technology is part of the main thing, right? So what, you have latitude here. What would be the current state of technology? Is it a concern for you? Is it a barrier? And what advice would you have to the group about the role of technology in any kind of virtual plus physical program?
I think like a lot of things in healthcare, it's the land of opportunity. If you look at, virtual reality, you look at, there's some really slick technology, and guess where it's not? It's not in the middle of my video visit. So there's a lot of things that I think we could be thinking about. Gamification of mental health, like, how can we bring mental health care to kids in a different way? So I think it's the land of opportunity. I think there's a lot of people with apps, independent apps, they're not integrated with the EMR. And that, for an integrated health system, we're looking for the strategic plays where we can innovate and integrate. So the innovation in isolation doesn't really meet the goal of whole person care. And so we're really trying to find that path forward. I think, secondly, using the tools we have better, more effectively, is a big opportunity. We're in the process of doing some things for pre-visit, for our virtual visits that replicate what happens when you go into a clinic. And so we want to get some of the rating scales and all of these things together in advance of that provider time. So when we get the doctor on video, the patient's fully ready, they have all the information they need. So I think it's the land of opportunity from my perspective.
I absolutely agree with that. And I would say, and I'm sure all of you have experienced this, we are overwhelmed with the number of organizations that approach us with apps and digital strategies to meet your needs. And I would caution people and be careful to make sure that you're actually looking at those devices that are FDA approved, and go cautiously with that. And then if you have, we are fortunate within Allina Health to have a very strong research division that partners with us and is able to help us structure research design and working towards evaluating outcomes. If there is a product out there that maybe is not FDA approved, but is working towards that. And so just to be cautious, because there's a number of vendors out there that want you to sign on and purchase. I could tell you I'm in the land of 10,000 lakes, and I think there's 10,000 addiction apps out there, and everybody professes to be able to address the addiction crisis. And just be cautious in that selection, and don't lock into one versus another until you really have vetted and done all of your homework, and partner with experts to help you make that decision.
That's great. Wonderful. Well, we just have a few minutes left, so I'd like to just ask each of you to, maybe share some closing comments, summarize some keynotes, or some inspirational guidance for your peers.
Yeah, I think about times like this as, it's a highly constrained, difficult economic time. And constraint can drive complaint, or it can force us to innovate. And so I think in mental health care, where better to spend your career innovating than serving people that need you. I'm so encouraged. One of the great things that came out of COVID, I think, is a decrease in stigma about mental health care. So some of the reason we're overrun isn't because they're all new problem. It's because I think more people were in a situation where they had to raise their hand for help. And so I really believe this is a renaissance time for mental health. I think it's going to be a defining moment, and what we do with it is up to us. So I'm very grateful for opportunities like this to talk about what could be, what we're all thinking about and working on. The work is hard, but the work is worth it.
Yeah, I really appreciate that. When we do our employee engagement survey of our over 4,000 mental health and addiction employees, the number one response from them is how they all resonate to the Allina mission and whole person care and appreciate that. And then the second is that they're so grateful for the team that they work with to meet this need. And I'm grateful for all of them at Allina Health, and have enjoyed significant support for mental health and addiction. We did some very foundational things 8 years ago when I entered into the company, and it was to address that concept around stigma. I remember going out to speak to our Minnesota NAMI executive director and talk about how would we address stigma. And she said, well, start with your own mental health and addiction team, because it's present there. Start at home and then go out to the broader organization. And we made it safe for people, our employees, to themselves to talk about their own challenge of mental illness. And it was a campaign we call Be the Change. We hoped that we have 27,000 employees, and we hoped for about 270 champions to really advance the cause. And within 2 weeks, we had 580 individuals that wanted to be champions. And so we had to start to that stigma point. We had to start at home and really lay that foundation. And then we started to really address. So if you're brand new, I think that is a very good first place to start. And then the second is we really needed to advance through, we're a lean organization and value stream is really foundational. We had to create efficiencies and demonstrate those with the existing programs that we had before we really ventured into other areas. And then the last is we're facing some very significant financial challenges. And this has been my career for 30 years, and I've been through this before. And I find that during some of the most challenging times in the healthcare industry, it really does advance innovation and change. And so I see it as, though painful, a real opportunity towards the future.
That's great. Thank you both. And thank you for your time and the generosity you've displayed in your insights and how your programs are going. I know I learn from each of you all the time, and now 500 plus of your colleagues have as well. So thank you very much for that. Moderator, we're ready to wrap. So thank you everybody for your Q&A, and thanks again, Dawn and Joe, for your time today.
You're welcome. Pleasure.
Sounds good. I just want to close by thanking Andy, Dawn, and Joe for an excellent presentation, and Iris Telehealth for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us today. We hope you have a wonderful afternoon.